I will admit I had to look it up. I had to use Google.
Josh is fine.
Okay, well, we are at 11 o'clock, and we have a lot to talk about today. I want to welcome everybody to our Houston chapter of the FMMA meeting. We have our chapter is co-sponsored by Green Imaging and by Next Level Urgent Care. We have really focused this year on, education beyond the free market principles, because our chapter seems to be comprised of people who are really, truly, working on free market principles, working on free market healthcare plans. And what we need is a little more sophisticated information, I think, than just what the general public is seeing about free market healthcare. And so one of the things that has happened this year is Catherine and I were invited to a session sponsored by Cicero Institute and the Texas Public Policy Institute in Austin. And I had kind of heard vaguely about House Bill 2002, but I really didn't understand the breadth of it and the implications. And so we were invited to a conference there to really, they were sounding out how to get this information out to the public, how to educate people that this is now in effect. And so we wanted to help with that effort. And I thought at least putting it out there for our chapter, and we actually invited people from all over, because I think one of their missions is to have this be a national movement. And so we invited, whoever wanted to attend, Texan or not, to join us and to participate in not only understanding this and the implications, but also how we spread the word. Ava, you want to move to our agenda? I kind of saw structuring this as number one, we have Josh, and it's Josh Archambault, who is with Cicero Institute. And I would have Josh really describe, what this bill is at present and the refinements that they are trying to accomplish with it that make it even more useful to all of us. And then we would move to questions and answers specifically about the bill and its refinements. Then move along. I'd really like to hear from I have some ideas about how this could be applied for employer plans and empower employers in the state. And so I think I'd like to kind of put my thoughts out there and then hear from the other advisors here, how you see this, really, because yes, we can impact this at the individual level, but the way we really get this to have deep teeth is at the employer level. And then finally, the last 10 minutes talk about how we extend this nationally. And I think, that's a lot to accomplish in this next hour. So I am Cristin Dickerson. I'm the founder and CEO of Green Imaging. And we are a national diagnostic testing service that's in 50 states. And we see this as a great opportunity for green imaging. So I'm going to let Josh introduce himself and then introduce the bill and the planned refinements.
Great. Well, thank you all for having me. I really appreciate the opportunity. Normally, when we talk about something like this, and just to give you a little bit of background about Cicero Institute, Cicero is headquartered in Austin, but is a multi-state think tank that has both C3 and C4 capacity. So that means that there's advocacy involved, but a lot of what we do is education, and this kind of falls under that. For most audiences, we would talk about what's wrong in healthcare and why these sorts of reforms are needed, but I am with my people, so I don't think I need to do that. I think you all generally understand the challenges that are out there, and many of you are actually trying to meet those challenges with the models that you're putting onto the market. So I'm very much looking forward to the Q&A. I'm going to be relatively brief just because I think what we're going to talk about is relatively straightforward. However, I do want to just give a little bit of a historical perspective of how we got here and why HB 2002 ended up becoming law. So just to step back for a second, I know a number of people have been working in price transparency conversations for decades. My own involvement started in 2012 on a bill that was running in Massachusetts, where I live in the Boston area. There was a very interesting debate around what I think at the time was probably one of the more robust price transparency laws in the country, and it allows you to call any insurer or any hospital or any provider to ask what the price will be ahead of time. And that was just a very interesting conversation to watch play out, and the special interests come out and try to kill it. And they took out a bunch of provisions in the bill that I thought would have been very beneficial. But for me, that jump-started my interest in the topic. And in 2017, in the state of Maine, there was a conversation with a broker and myself, and we were talking about ways to align incentives. If we weren't going to be able to tackle some of the pernicious third-party payment issues that we have and the tax treatment, and many of you are familiar with those challenges, what could we do? If we were going to try to tweak the playing field, what could we do at the state level? And it turns out, weren't alone. There were others thinking this way. We're thinking about allowing patients to be able to be value seekers themselves, and providers or other service providers that maybe weren't able to be in network with a provider. How do you allow patients to access those services and not be discriminated for doing so? And so the state of Maine passed a law somewhat along the lines of what we're going to talk about today. And there were a number of individuals kind of interested in this. So what ended up happening came to a culmination. Representative Tom Oliverson, who's a MD in Texas, had some personal experiences along these lines that got him thinking about this. We at Cicero, given some of this history of my own personal involvement at state level policymaking, and then Texas 2036, which is another group that was active in this space, really started to coalesce around House Bill 2002. And the goal here was three or fourfold. One was, how do we increase patient choice? How do we reward providers who are offering what I'm calling, more ethical pricing, regardless of their network status? How do we make patients more connected to the pricing of services going forward? And how do we remove some of the administrative bureaucratic costs that are out there? And so that's where this bill kind of came forward. The bill is relatively straightforward. I think the language was actually shared with you in one of the invite emails. But happy to share it again. In essence, what the bill says is, it just says, if you're in the fully insured market in Texas, and there are some limitations on this, which I will say at the very end, if you pay directly for a service that's medically necessary and it's a covered service, regardless of the network arrangement, and as long as it's less than the average rate that you would pay in network, then your insurance company has to give you deductible credit. So you can turn around and request deductible credit. So within that description, you've probably picked up on already, there are some limitations to this. It has to be a medically necessary service, has to be a covered service. So you can't just go anywhere. You can't go anywhere. It has to be to get the deductible credit, it has to be below the average discounted rate, is the language that's used in the bill. And this only applies the legislative compromise was that it only applies to PPO plans. So it's in the fully insured market. So it doesn't apply to other plan designs there. So the states of Tennessee and Texas passed laws similar to this. And I'm happy to talk about it. That we at Cicero have a model legislation that is far more robust, has other provisions that we would like to see added in Texas that I think continue to align incentives, paying patients directly when they become value seekers, allowing third parties to be part of that savings payment, if you will, to help facilitate it, which we can talk a little bit more about in Q&A. But that's the gist of what HB 2002 is, and we think it's a great opportunity for providers that are price competitive to be able to seek out patients to come see them, even if they have insurance, and not, we've all had those family members who say, well, I'm already paying for this insurance. I want to make sure I get my dollar's worth. I want deductible credit, so I'm going to go to the higher cost in-network option. This at least allows for the option for the people who want to do something. I'm really excited about folks like yourselves who are on the front lines, who are taking an interest in this. We admit in the policy world, we don't always get this right. So we are very much looking forward to any critical feedback you might have, additional suggestions on how to tweak the law, how to add to it. We've already been having some of those conversations. but also helping us think through, what does this look like into? But it's really helpful for us to hear back from you of, hey, this could be applied in this way for this kind of services, or we see a big opportunity here, because lawmakers frequently don't hear that. Policymakers don't hear those stories. They think that this is not possible. It takes somebody like Rep. Oliverson to step forward to say, enough is enough. Let's at least open this option. If nobody takes advantage of it, so be it. But we want to at least provide these options. We want to hear those stories about how it helps somebody with chronic conditions, how it's helped a small business navigate in this world, which in Texas, in the PPO market, is largely the small business market, from what I understand. We want to hear from those of you that say, hey, this is a new business opportunity. I would launch a company in this space because now I know that if I'm offering price competitive products, it's not dependent upon me having a contract with the largest 3 insurers or something like that in the state. So those are the sorts of things that would be really, really helpful to us. But with that, I will pause and turn it back over to you, Dr. Dickerson.
Right. And I'm going to ask you the 3 questions that I have that I actually asked in Austin, which are, obviously, right now, because I'm not in network, this would likely be applied to out-of-network deductible, not in network. Number 2, we talked about medical necessity, and I asked Oliverson about, because one of the things that happens right now, for things like ultrasounds and some exams that we offer, that, so on some plans, members can turn in the, the receipt and have it applied to the deductible. It's the ones where a pre-cert is required, that is how they show medical necessity. Although I would disagree strongly that that's a good indicator of medical necessity. That's, how it has been done in the past. So let's start with those 2. I think that's a good starting place.
Yeah, all good questions. And I think you highlight challenges of passing legislation that's 2 paragraphs or 3 paragraphs. It often prompts some of these questions. So the short answer is, I think we're having conversations with the Texas Division of Insurance to see if they would be willing to bring some clarity to some of these very legitimate questions. Then, of course, we're having conversations about Representative Oliverson going back and tweaking some of these to bring some clarity. So I think the short answer to the first one is it would depend on the insurer, on how they decide to apply this, whether it be the out-of-network deductible or in-network deductible going forward. Our model language addresses this, and model language doesn't always get to be the final version of a law. But yeah, this is, I think a plain reading of the language would have you believe that it should be applied to your in-network deductible. However, I think insurers and their lawyers could argue, we're not forced to do that, so we could apply this to their out-of-network deductible. Does need to apply the annual maximum out-of-pocket expenses, so that's clear in the legislation, but I think there's some cleanup here that could be very, very helpful. On the medical necessity one, I think these are ongoing conversations. I know in Texas there's been legislation around changing the prior authorization, gold carding, I believe it's called. So obviously, depending on what the state statutes are around that and what's required, I think the goal here, our goal on the policymaking side, is we want to provide the playing field for these issues to emerge, to then be cleaned up appropriately and follow up legislation. We anticipate there will be bumps. So for instance, another one in here that we wish they had brought more clarity in the final language is they never define average discounted rate within your network. They never, and that could be interpreted a few different ways of what average means, mean, median, across your product line, all your plans for your specific plan. And so there's definitely some work to be done here to bring some clarity. I think we, at the moment, as we've had these conversations, have believed that on this one, on the medical necessity side, that the insurers will probably continue to require you to get authorization ahead of time going forward if they have it, But in my private conversations with a lot of insurance representatives, I think they're questioning whether that system's worth it. So I'm hoping that in the next couple years, we'll see more and more insurers say, look, we only are requiring prior authorization for a certain high threshold of services. Everything else, it's just not worth the time and effort that we're putting into it in the back and forth and burnout and frustration that we're having with providers. So I know that's not a satisfactory answer, but that's kind of been the conversations to date.
And that's pretty interesting, though, because, that's not the majority of exams performed in a self-funded healthcare plan or in a healthcare plan in general. The majority are bread and butter image, at least with imaging, it's bread and butter studies that don't require that kind of authorization. And then as far as the proof, if anybody ever needs proof, let me tell you, we've got reams of claims data. And so most of the people I see here who are offering direct contracting, their prices are a small fraction of the average in that of the average discounted allowed amount. So I think that's easy to prove. So we had a hand raised there. It was Daryl Calderon.
Yes. Hey, Dr. Dickerson, Daryl Calderon, how are you?
Good, thank you.
Hey, so what's the denial rate, I guess, is the question, since it's only for the PPOs. What have you seen?
There's no data available yet. This has only been in effect for a little while. The other thing is, I'm not sure we'll know outside of anecdotal. There's no reporting requirement in the legislation. Our model bill does have some reporting requirement and does provide an opportunity for patients to push back and go through the commissioner or supervisor of insurance. That's not in the Texas bill. So we are more just curious to hear from individuals that try to take advantage of this. And I think anecdotally, we're hearing in Texas of more and more people, as awareness grows, trying to take advantage of this. So I think we're really, really curious to see how this plays out. And I do see Tanner Aliff here from TPPF, who was involved in this effort as well. Tanner, I don't know if you have a question or you had a comment on that specific question, given some of the conversations you've had around this.
No, I was going to ask a question. Well, I know that there's a little bit of lacking in the reporting aspect of it. There were some protections built in for how long like an insurance company or PPO plan can sit on this. I believe it's like within 30 days that you see the application of the credit actually extended to their in-network deductible, at least here in Texas. Josh, is that what's going on in Tennessee too, or is there any protections or enforcement follow through?
I'm not aware of any in Tennessee. I think what's been really interesting is the departments of insurance, I think, we're stretching them a little bit to think outside the box in a good way on these fronts. And so I think we're really curious to see, do they end up issuing regulations? And usually, we get a little bit of heartburn when that's the case. But I think given the conversations to date on some of these fronts, especially in Tennessee, the other unique thing about Tennessee is they actually extended this opportunity to public employees for people who are on the state plan. So we anticipate over time in Tennessee, there's even more people that qualify for these to be able to get deductible credit and shop around. So I think it's going to be very, very interesting to watch to see, are the departments hearing more and more from people who are running into are their insurance companies giving them trouble, or the insurance companies just going along? Because we've heard those examples too, where initially the insurance company says, well, I don't know if we would do something like that. And then they see the final bill that gets submitted, like, oh yeah, we'll give credit for it. That's fine. So it's going to be very interesting to watch this play out.
Well, Tanner, thanks for joining us. And I think that's where maybe we can help as well. I think we could potentially put together with some of our organizations from Market Medical Association, Health Rosetta, put together some a kind of a data repository on successes and ask people to submit successes and failures and see what we can demonstrate for you. So I'll work toward that effort, because I think that would be huge. I was going to say also, I think those of us who are providers in this space, we have moved to being able to offer HCFAs or electronic claims. I think having that HCFA is going to put they're going to be less likely to say you're not providing the data we need, because it's the same data that would go through on a traditional claim with the health plan. And so I think the more we can do those things, and it's going to decrease their ability to argue against this.
Yeah, and Dr. Dickerson, you had raised that in Austin, and I think it is an important thing. In fact, there's a bill in Iowa running right now that added a provision along those lines. One of the main objections that insurers have voiced is they had said, well, we're going to have to spend all this money on administrative, redo our systems and all this sort of stuff to be able to deal with these sorts of again, claims is not the right word, but receipts coming in, if you want to call them, related for these direct pay services. And I think anything that you can do that makes it look closer to what the claims they normally process will reduce the friction for them. And I think most of the insurers, not all of them, but most of them over time, I think we made the counter argument to them, like we're glad that you agree that people are going to take advantage of this, and that you agree that there are opportunities out there for people to find a better deal. And of course, they then go back on their heels saying, oh, no. I mean, we negotiate great deals. And we say, great, then people won't even have this opportunity to go out of network and find a better deal. So I think it's just a little bit of push and pull with the insurers. And over time, as the bumps get exposed, and please tell us of them if you're running into them. If you have a patient that comes to you and tries to submit for deductible credit and runs into a problem, we want to hear about that. Representative Oliverson wants to hear about that, because we can shame the insurers to a little bit, for lack of a better phrase, to put them on notice to say, look, the intent here is for you to honor these. And if there's not a major problem here, you need to honor these. So please do pass those on to us.
Josh and Tanner, I have if we wrote kind of a patient-friendly summary of this, we have web requests all the time, or a script that our, concierge staff can use. For this, I know Christopher Merkel, I know there are other providers here who would be very interested in this, so that we're not misinforming. We don't want to misinform, but, if you all would approve a script that we put together, I think that would be really, really helpful. And then, I think, Ava, we can put together some type of way that we can ask that people who are attending this and people who listen to this recording can submit to us, some successes and failures, so that we can try to get that data across to you. I think that's, you're asking for ways we can help, and I think those are a couple of ways we can help. And if anybody needs some, I would also say, providers, if you don't currently have, the ability to create HCFA forms, I know some inexpensive ways to be able to do that without, the kind of 6% charge that you would have with a billing company. So there are some hacks for that. That I would be happy to get across. Any other questions before we move on to how health plans could potentially work with this?
Hey, maybe just one, if I could throw it in. Hi, Josh. Good to see you on Zoom again. I'm Jim Jusko from Excel Health Plans. It could probably, it could be useful to maybe also have almost like an FAQ or something that, along with what Cristin just said, helps people understand what the process would really be. Especially in terms of, I found a service for this price, and how do I find out if that price is higher or lower than what the average negotiated rate is? Do I get that easily and quickly online? Do I have to call the carrier and ask them? And then what exactly is the comparison? Because for some services, there could be multiple components. Let's say there's a service at some provider, and it's got half a dozen CPT codes. Is the average done on a code by code basis, or is the average done taking them as a whole? But one provider's service might have this 6 CPT codes. The other provider who says I do that service might have 10 CPT codes that they bill for that service. So it would be really interesting to understand, a little more granularly, just what it means to say this service I'm getting for less than the negotiated rate.
Jim, and I think that's a really good point. And, when we're doing our claims data analyses, we rebundle the imaging codes, the HCPCS codes, which will include the radio tracer and any medications, the contrast, and then the professional and facility fees. And so I think the more those of us who are getting that kind of data from, we certainly know plenty of people in Texas are doing bundled surgeries and have that kind of data. Green imaging is a good resource for outpatient diagnostic testing. And I think the more we can pull some of this together and provide it, when it's needed, if the carriers start denying these, I think we all have good data that, I don't know how many, I've even done data analysis for ERS. So I have really good BCBS data in Texas. So I think our ability to pull together in this effort is going to be huge, because I do predict we're going to be having some battles.
Yeah, it will be interesting, because what I love about this is it operates at a consumer patient level, and it drives the kind of behavior I think would be awesome for the system. But as soon as you have consumers doing something, making it workable and straightforward and easy, so they'll do it again and again, and not just once and throw their hands in the air and say, I couldn't get good info, I didn't really know. There's all that process. Consumer experience would be the phrase in the lingo to really think about. But I think it's awesome, and really pleased to see all this.
Yeah, let me just, for some historical context, I mentioned in the state of Maine, they passed something similar to this in 2017. Now, they put some limits there as well, and there was only in the small business market. It was limited to out-of-network providers in Maine, New Hampshire, and Massachusetts. So there were some other parameters. The issue that we heard about in Maine, in which they actually went back and passed additional legislation, it was not the deductible credit by the insurers. What the insurers were doing, though, is they were denying referrals from out-of-network providers. So DPC docs or others would say, you need to go see so-and-so specialist. And the insurer would say, wait, you can't do that. You haven't seen an in-network specialist first. And they were basically mandating duplication of services. So we went back in with some others, providers and others, and added legislation. This is in the model for Cicero that says, you can't deny it. You can't deny the referral just because the person was out of network. If it's a medically necessary covered service, like, you need to cover it and give it. So that's kind of like a secondary issue to what we're talking about. But to your point, Jim, like, you want to make sure patients don't just attempt this once and don't do it again. I think there are some of these things that need to be worked out to say that, okay, you saw the DPC, you went to green imaging or whatever, and now you need to do some follow-up care based on what you found. The insurer shouldn't force you to have to go see an in-network and redo the imaging or something like that.
I think that's a great point. And, especially with the kind of advanced primary care that's being launched, Houston Business Coalition on Health is working on their own health plan that will have advanced primary care. And so that's going to be something that we need to make sure, is protected in Texas. So that's a great point. Moving across the lines now to how employers could use this bill. I've been really thinking hard about this. One of the things that I've thought about is it does cushion the blow a bit of high deductibles. I was on the phone this morning with a product called Patient. It's Paytient it is an employer option. Obviously there's going to be a PEPM associated with it, but it's an employer option that lets employers offer 0% financing loans to their members to pay for care out of pocket. And so that to me is one of the things that could really fit in nicely with, here, although the deductible might be, an employer might use it as an opportunity to raise the deductible sum, their members would still have the option of getting the care that they need. Because right now we know that people are not getting the care they need because they can't afford to pay against their deductible. It's just not there, which is why the zero out-of-pocket options have really been flourishing. And the other opportunity, and me as both, to some degree, even though we've been around a long time, we really were more of a startup on scaling about 3 years ago. So as a growing company and as a small employer, one of the things that I could potentially see is, one of the arguments, there are two things that we get the arguments for people going fully insured, even though they might have a big enough member population to go self-funded, is number one, their members want the Blue Cross Blue Shield card. They want that, seal of approval, even though we know that, they're approving every doctor in the country. There's not really much of a seal of approval there. And then the other one is that if you're a startup, you don't want the liability on your books of a self-funded healthcare plan. And so, what this might allow, and I'm open to anybody slamming this down, but what I saw is maybe have a high deductible, really use the fully insured plan as a catastrophic plan and allow zero out-of-pocket options for the oil changes and the less expensive care, and and fund that with a Stripe card or whatever, however but it gets rid of the problems we see with the first dollar exclusions with the HSA plans. It gets rid of a lot of that noise and plan design that direct contracts are being subject to in that kind of level funded space. And, I think it has some potential there. And so I'd love to hear from the advisors who are on and anybody else who thinks that there's some opportunity there. Well, I'm not hearing any negative right off the bat, but it does take some thinking, I think, for us to figure out how this can, Nancy, please. You're an expert in this space.
Had to unmute myself. Okay, so I'm not in Texas, so you can take this with a grain of salt. I'm a non-Texan. However, I do agree, and I do that already. We use the HDHPs without an HSA component so we can do the things that we need to do. So yes, I think that's a really great way of self-funding in the fully insured market for, the smaller group space. So yes, I love that idea.
Great. Well, she's broker of the year in so many different spaces. I think we got a seal of approval there. And anybody else have any comments in that space? Jim, how about you? You have some experience in the level funded space.
Yeah, my mind probably goes to a different area because my experience is a little more in level funded, which often caters to smaller, medium-sized businesses. And it's about the rest of the ecosystem in that space. It's hard to imagine all TPAs being able to handle the administration of something like this, where individual members submit their costs for something and then apply it to deductibles. That's what I think I anticipate some pushback, is that probably TPAs would say this is another burden for us to administer. But
good point.
Maybe ways around that. I think it's worth doing. I think it would be great in the level funded space. Again, it's just another place where individual members could find ways to savings.
Nancy.
So I agree with you. However, that's their job. And insurance started out as indemnity. You had a claim, you submitted a claim, and they paid for it. They're perfectly capable of doing it. They just may not want to, and it's going to require, some pushback. This is your job, to pay claims.
And they're not really doing it.
They're not doing a great of a job anyway, but I'm just saying that this is what insurance is for. So
agreed.
They need to do that, and it's going to require probably a swift kick in the teeth to get them to do it. But you find the ones that will, and that's who you give the business to.
I couldn't agree more. That's how.
And they're adapting. I don't want to be unfair. I have spent so many hours on weekly meetings with TPAs this year, and they are really trying. I would say on the whole, they're really trying to adapt and trying to make things like this work. And I think we need to give them time. These are legacy systems, and we need to work with them and make it easier for them. Gary, you had your hand up?
Yeah, so I think I work in more of a mid-level market where 50 to 500 space, and I think as you go upstream in terms of the number of employees, there's this constant battle between the CFO wanting to cut costs and the HR director wanting to remove noise. And so the more different moving parts you have toward the health plan, sometimes you if the HR person has got a strong enough, I guess, personality or she's that person, I don't want to always say she, but that person is going to overrule and take some of the creativity we as brokers bring to the table.
Okay. And Tanner.
Yeah, I mean, I agree with Nancy. The plans need to pay, including the TPAs. But something that's been not called out, but I've been seeing good faith on the insurer side of things, is that there was initially a little bit of resistance to HB 2002, but when you sat down, I got the chance to sit down with them, some others talked with them, and then once they kind of realized, like, oh, hey, this is a way for you guys to have your members avoid, like the overpriced negotiated rates of the most powerful hospital systems without breaking the anti-competitive clauses within your prior network agreement, like the anti-steering and tiering stuff. Like, this is a way if you guys can be a facilitator of some price information that's not going, like, where you don't have like a pay incentive in the plan itself, but if as a consequence, patients end up going to a direct pay place for MRI or labs or colonoscopy, which is way better than your negotiated rate. There'll be some uptake from them because, again, when it comes to like the medical loss ratio, it's an accounting game, and they are taking some losses just with like the provider supremacies from some of the largest hospitals, and like even the BUCA struggle with like Ascension here in Austin, right? So there is like some buy-in on their part, and it was enough to get them to realize that there is a value add for seeing some of the members go this direction and not have them hit their deductible. So they actually were excited to have like a smaller amount applied deductible. And also in the rules in Texas, something that was kind of clarified and worrisome is that, Josh, I don't know if you know this, but where any events out of network, it will now be counted towards your in-network deductible. And the plans have agreed to that.
That's fantastic. That's great to know. So I think any other hands in this space, and then I think we move to how we extend this nationally. And I think, Jim, you have a little bit of thought in that space, and then we'll let Tanner and Josh close it out on that.
Yeah, just one. And then I apologize too. I'll probably have to jump, unfortunately, right after this comment. But overall, I love this. The idea, there's different approaches, certainly, from the work that I do with patientrightsadvocate.org. They're looking at things, two strategies for taking things nationally. There's always just, push it out to more and more states. And then, of course, looking to work this into federal legislation. And there are a number of kinds of additions to get worked into different bills. There's a price transparency bill right now in the House and another one in the Senate. Senate one is particularly interesting. And so the idea of pushing, standalone national legislation or folding this into an existing bill at different points is all possible and exciting to think about.
And congratulations to you all on the Super Bowl ad. I didn't get to see it. I watched the whole thing and I never saw it. And some other markets didn't.
It wasn't in there.
Mattress Mac instead.
I know. We saw Mattress Mac instead. That's right.
Yeah, it wasn't a fully national ad. It ran in select markets. So if you had more presidents and senators hanging out in your market, maybe it would have run there.
Okie dokie. Well,
Thank you
thanks
all.
and congratulations to y'all, and thanks for what you're doing.
It was a great ad. I saw it elsewhere. It was great.
Oh, cool. Yeah, thank you. All right, have a great one. Thank you all.
Okay, thanks. Tanner.
Just some closing remarks about how to expand this to other states.
Yes.
I think, again, it's kind of some of the stuff where it's like the biggest opposition is usually the plans, because the plans will treat this as a mandate. And I think by leveling with them and saying, hey, there's a value add for playing ball with the direct pay providers, who would probably be the ones where you'll see like actual great prices and rates come from, they'll be using this. And again, kind of harping on the fact that they have their wings clipped a little bit with all the anti-competitive clauses in the provider network agreements has been the best way to kind of break through that shell. It's going to come from like the mid-tier plans that will see a lot of value add this value add for this, especially if they have like network adequacy problems and they're trying to narrow the network. They'll probably see a lot of utility in this. Some of the BUCAs will play, and like ultimately their involvement will determine a lot of scaling. But as far as like getting this conversation started in a state, it's about kind of meeting early on with the plans and seeing where their head's at. But if you kind of sell them this is a way, because I noticed that the anti-competitive contracting fight has been more confusing and harder. And then also like, I don't know if y'all heard about HB 711 that passed here in Texas. Theoretically, the plans now are supposed to be freed from anti-tiering and steering clauses within their provider network agreements, but there's a bunch of TDI or Texas Department of Insurance regulation preventing them to do so. But I noticed during that fight, there was just so much like the doctors wanted to protect the all or nothings, the payers, like, and the doctors wanted the most favorable nation clause off the table. And it became kind of like this really awkward horse trading show near the end of it. But as far as this type of bill, like HB 2002 or HB 1213, if you kind of say this is a way for y'all to get some control of your plan, to make your plan actually useful to people, especially if your plans have if you have a lot of high deductible plans, you'd be surprised the ears you'll get from the insurance companies. And that was really cool to see. So I think that's just something to understand, that anti-competitive contracting is really tied up into this conversation. And that's just the best way I've been able to talk to the insurers. Also, I think Josh knows this too, is like a huge thing in Texas was like, hey, this is a way for y'all to save money. Like truly, right? Like if you have a whole bunch of people that you're able to secure only like an MRI, that's like $3,500 with Ascension, and green imaging exists. Don't you want to not have people go and take that $3,500 brunt in their deductible? The answer is often yes. So I think also the way that you talked about it, Dr. Dickerson, was really important about just like highlighting that this is a way to like make employees, individuals okay with having a higher deductible plan, knowing that there'll be a kind of like a community of providers and plans and other Billy to Turquoise Health that can help them navigate the information side to get connected to those really great direct pay rates. And I think part of this is just my last comment is that Josh and I, when we kind of did like this cash price surveying map in Nashville, that's like we created a map identifying like, oh, there's this place called Advanced Correctal Imaging, right? That had like a $541 colonoscopy price for all fees, like commonly associated fees included, while Vanderbilt, like less than 2 miles away, had theirs charging at like $4,546 or something, right? And when you put that in front of legislators saying, hey, there's all kinds of prices out there, but the one thing that's really notable is that all these prices out there are typically lower than what hospitals are charging, and also what the insurance companies are able to negotiate across the board. And so if you actually give an ability and a reward to a patient and provider, for the provider to offer a great direct pay price, and also an incentive, actually having the deductible credit applied to the patient's in-network deductible, it really clicked for a lot of legislators here in Texas and other places.
Fantastic. And Josh?
Yeah, I'm going to put a link here in the chat. This is for Cicero. Model legislation is there. We have a white paper on the concept. We are very open to working with anybody, whether it's continuing to improve the Texas bill, and again, work very closely with Tanner in Texas. There is a bill, as I mentioned, in Iowa. There's a bill in Arizona this session. I don't know if there was talk of one in Florida as well. Going forward. So we're hoping that this conversation can continue to expand. Some of the issues that have been raised, just to Nancy's point around MLR, this is something we're very aware of, and the model bill definitely addresses. We would like to see states, including Texas, add a savings incentive that's paid directly to patients. And that's when you can really put these sorts of reforms, I think, put rocket fuel into them. But we also know that we want to be in touch with people in the market to making sure that we're moving the needle in a positive direction. So if you have thoughts on this, if you have data Tanner was subjected to calling, I don't even know how many hundreds of places to get cash prices. If you're in a market where you can provide data for us to put out research showing that direct pay or cash prices is very competitive, that's helpful to us, because the reason we did the cash survey, Tanner and I did that together, was because initially lawmakers don't believe that these things are out there, that there's rates out there, that there's more than one option. So if you're connected to a company or you're in an area where folks can give us some data showing us that cash rates are very competitive, that would be incredibly helpful for us on the policy side to be able to build the case for pushing this reform in other places.
I'm also very interested in making sure doctors are on the right side of this. I think they need to think differently about this. I spoke at the Texas Medical Association's annual meeting last year, and so many of these doctors had never really, and many of them were poised to do great direct, rheumatologists, oncologists. So many of these people had great opportunities to do subscription-based care or cash pay here, and they had never really thought about it. And I would really love to introduce you to my contact at the TMA. And one of the things that the TMA has the opportunity to do is to prove it to doctors, and that is they're offering health plans, and they're offering traditional health plans. They're screwing these doctors, these independent doctors. Excuse my language there, but they really are. These are not good plans for the doctors themselves. And so I think if they could put together more of a, maybe this kind of health plan that we're talking about, where it's more of a catastrophic plan, the doctor funds, issue stripe cards or whatever it is, or offer something like Patient to get patient, the members the financing they need or the cash they need to pay for the exams, and we start crafting some of that, we can get, help doctors understand that. And it's coming. I mean, I'm actually speaking at the American College of Physicians and Surgeons this, I think it's in the fall in San Antonio, and it's their national meeting. And I think doctors are starting to get the idea that they need to be changing the way they practice. And so I've seen that be biggest increase in my speaking engagements are at the physician end. And so I think that's very heartening. And I think that's a movement that needs to happen. Anybody have anything else? I think this has been super helpful. I would love it if you drop any other ideas for this kind of meeting. I think one of the things I want to look at is kind of the problems that we've seen between direct pay providers. And we're not going to talk any names. We're just going to talk case studies. A problem that arose between direct contracting providers and how they get implemented in plans. And I'd really like to have some smart people on there to talk about how we can avoid that and be more creative and make those plans hum for the direct contract providers so that we maintain them in our ecosystem. I think that's super important. If they start telling patients in this arena even that they're going to be able to apply it to their deductible and it doesn't happen, that's going to be, a failure. And so I think Josh and Tanner, I've got two things I'm going to do. I'm going to try to get a script together that we could put in front of our patients. And then I also want to introduce you to my contact at the TMA. I'm sure you all have some, but he's really on the physician end of things, making sure that the physicians feel like they can engage and do direct pay.
That's awesome.
I appreciate everybody's input and attendance today. We'll push out the recording, and if you would share it with your contacts, that would be very helpful, I think. And look forward to continuing the discussion. We'll probably do a follow-up to this next year and see how it's really going. Thanks, everybody.
Thank you.
Awesome.